Good morning, good afternoon, and good evening to everyone. Thank you so much for joining us today on this webinar on overcoming the blame culture in the maternal perinatal death surveillance and response. Next slide. I am Francesca Palestra, and I'm a technical officer in the maternal health team at the Department of Maternal, Newborn Child, and Adolescent Health and Aging in WHO Geneva. So I'm very happy to welcome you here today, and also with all our speakers that I will introduce in a moment. I would just like to start saying that in order to reach the SDGs, it is really imperative for us to address maternal and newborn health, service delivery, and quality of care. That's why it's really important for us to address the end preventable mortality through MPDSR, which is a really important tool that we have in order to do this. And successful implementation of MPDSR requires a no blame and no shame and no name environment. Issues around blame have been really obstacles in the MPDSR implementation. That's why we're here today to hear from our speakers to see what have been the strategies that they use in their local context to really overcome these barriers for really improving the health of women and newborns. So next slide. I would like then to present the agenda to you. We will have a first part, an introduction on the new manuscript, Overcoming the Blame Culture, with key strategies to catalyze maternal and perinatal death. Then we will have a rich panel discussion with our speakers from Namibia, Ghana, and Uganda. And then questions and answers and closing remarks. Next one. So please, when we will have the questions and answers session, please write your questions in the chat box, and then we will answer them with the panelists. Next slide. Now I would like to introduce Mary Kinney, who is a researcher at the School of Public Health at University of Western Cape, South Africa. So she will help us in understanding a little bit more the blame culture issues and about the key strategies to really improve the MPDSR implementation. Thank you so much, and over to you, Mary.
Thank you, Francesca, and greetings, colleagues. Today, I have the privilege of sharing the work our team has done to support a blame-free implementation of maternal and perinatal death surveillance and response. And this work was supported by the MPDSR Technical Working Group and the Countdown to 2030 group. Next slide, please. It's been a collaborative effort. We started in 2018 when the Technical Working Group set up a subgroup to focus on blame and understanding how the blame culture impedes MPDSR implementation. This group conducted a literature review and then drew from a scoping review that was ongoing on MPDSR implementation factors. One important piece of literature identified was a framework developed by Gwyneth Lewis on the cultural environment of maternal death in near-miss reviews. And that was published in 2014 in the British Journal of Obstetrics and Gynecology in a supplement on quality of care. And this was done in reflection of the large FECO-Logic study that took place in 8 low and middle income countries. So we wanted to build from this framework and then also link with the scoping review in order to identify strategies that would address and overcome the blame culture relating to MPDSR. This was included in the WHO materials to support implementation guidance document as a module, and then published as a commentary also in the British Journal of Obstetrics and Gynecology with country examples and in the context of the pandemic. Next slide, please. This work was done in order to support implementation of MPDSR to improve maternal and newborn health outcomes and reduce deaths. So prior to the COVID pandemic, there was an estimated 4.6 million maternal and newborn deaths and stillbirths each year. So this is a huge burden. And we know that during the pandemic, maternal and perinatal outcomes have worsened, especially in low and middle income countries, highlighting the need for us to galvanize MPDSR and use the tools we have to strengthen health systems and end these deaths. MPDSR, for those who may be less familiar with the intervention, it's a health system process entailing a continuous cycle of identification, notification, and review of maternal and perinatal deaths, so the surveillance side, followed by actions to improve service delivery and quality of care through response. It's a complex intervention process with a number of components and involves multiple actors and teams to collect, analyze, and apply the information at multiple levels of the health system. It does reduce mortality if the audit loop is closed and recommendations are implemented. Next slide, please. Successful implementation of MPDSR does require a no name, no blame, no shame environment, which is grounded in 3 ethical principles: confidentiality, autonomy, and respect. And the concept of blame relating to MPDSR is complex, taking different forms, arising for different reasons, with varying perspectives between settings. No blame is integral to no name and no shame in MPDSR. And if a blame culture persists, MPDSR will fail. And the consequences when these principles are not followed are demoralized and demotivated healthcare workers, punishment of healthcare workers, either through litigation or even violence in the community. Fear of punitive action results in less support or resource allocation and can result in unnecessary referrals or misclassification or underreporting of deaths. And it can result in a weakened health system and lack of community trust in the healthcare system. Next slide, please. As I mentioned, we were linking to this scoping review, which has now been published in Health Policy and Planning. And in that study, we identified 42 studies in low and middle income countries with information about the blame culture, mostly at the facility level. And what we found was that fear of blame is widely recognized as a barrier to implementation. We also found that there's a lot of learning on blame culture, but little application of the learning is documented. And again, the concept of blame is complex, has different explanatory reasons for it and different types. And we know that people, relationships, and communication are core factors, but actually very little information has been published about individual experiences and relationships. So just some screenshots of some of the studies below here and the link to the scoping review if you want to learn more about what we already know. Next slide, please. So building from Gwyneth Lewis's framework, we considered that the blame culture needs to be considered at multiple levels of the system. So at the micro level, individual responsibility for and ownership of the MPDSR process needs to be considered. And this requires health workers embrace a positive attitude of lifelong learning and behavior change to improve maternal and perinatal health. It relies on health worker commitment and ownership to be part of the process, and for individuals and teams to be willing to change or self-correct and implement solutions. At the meso level, we think about the organizational culture. There needs to be an enabling environment to support implementation. And that requires an organizational culture of learning, which is a critical part of quality improvement. And then the final level, macro level, policy and political supportive environments require that national policies initiate and support implementation, such as guidelines and legal and other protective frameworks. And it also is facilitated by political priority for maternal and newborn health with corresponding investments to deliver quality services. Next slide, please. Our working group identified 10 strategies to promote a positive implementation culture of MPDSR after reviewing the literature, adapting this framework, and through consultation with the wider MPDSR technical working group. And as you can see, it includes 3 levels of the system, the macro, meso, and micro level, and these 10 key strategies, which I'll speak to. And you can see that the colors are all kind of blended because there's a lot of overlap between these strategies, and there's a lot of intersection between them, and they occur at all levels. Next slide, please. So the first strategy is to ensure MPDSR policy and planning includes national guidelines, clearly explaining the purpose, the process, and how to conduct blame-free MPDSR, as well as legal frameworks to draw a distinction between the audit process and appropriate disciplinary action. The second strategy is to ensure national prioritization of preventing maternal and perinatal deaths with the resources to implement recommendations. The third strategy is to harmonize MPDSR in routine monitoring systems to standardize processes and enable accountability. If the data becomes part of the system, it will be more routine and result in less blame. The fourth strategy is to create and advocate for an overall enabling environment for implementation. And while this does include material and human resources, it also needs to consider the overall organizational culture of learning, accountability, and transparency. The fifth strategy is to strengthen leadership within all professional groups engaged at all levels. And that's also ensuring engagement with an MPDSR focal person at all levels, national, subnational, facility. And those focal persons or the people who are working with them, they need to know how to facilitate meetings and mentor others in a way that is not blaming. The sixth strategy is to nurture team relationships, and that's linked to the strengthening of leadership, because we want to see those who are participating in the audit meetings having continuous engagement, having a team approach, and that requires support from hospital management, as well as deliberate efforts and strategies such as mentorship. The seventh strategy is to ensure audit meetings take place regularly and staff regularly attend. The literature shows that the more people attend, the more practice they have, and the more embedded the process becomes, and the less blame there is. The eighth strategy is to establish and apply a code of conduct, or an audit charter, as it's often called. And this would have clear rules around the purpose of the meeting, expected behavior during the review meetings, and the confidentiality of the meetings. The ninth strategy is to promote individual awareness of their roles and responsibilities and competence to complete the task in a non-blaming approach. And then the final strategy is to engage communities in awareness about reporting and participation in MPDSR cycles when it's appropriate. Next slide, please. The commentary includes 3 boxes with examples from countries which have had recent studies done and have undertaken specific efforts to overcome the blame culture. So for each of these examples, multiple strategies have actually been applied to address the blame issues. So for example, in Zimbabwe, an assessment by MCSP found that the interdisciplinary nature of audit meetings demonstrated buy-in and ownership in the process by all staff, and it also reflected strong facility leadership. The assessment found that there was little fear or blame associated with the death review meetings reported. And as we can see from this quote, everyone attends the meetings all the way to the driver, because when we have a case to transfer, he knows why we need to move now. So just an example of one of these strategies. In Tanzania, also an MCSP assessment found that some facilities had codes of conduct that were either read at the start of the meeting or were embedded in a staff letter inviting the team members to join the MPDSR committee, as shown here. And this demonstrates leadership by hospital management to promote a positive organizational culture. And the final country case study was in Bangladesh. The success of social autopsies has been due to implementation in a blame-free environment. And that's been enabled by careful preparation to ensure family consent and engagement, and skilled facilitation by someone familiar to the community in order to avoid blame in the meeting. Next slide. So just in conclusion, we know that in order to overcome the blame culture that currently is impeding MPDSR in a number of settings, action at all levels of the health system is needed. Applying these 10 strategies can create a healthy culture and environment for implementing MPDSR, and future research needs to understand how effectively these strategies can change the blame culture across diverse contexts, and that will require more investments in implementation research. And I would really encourage us all to act now. We know a lot. There's been a lot written, there's been a lot documented. There are excellent resources that are being provided, and some of those links are here. So please access and use the materials to support blame-free implementation. And again, thank you to the team who worked on this module and commentary with us, and we hope it's useful to your efforts to improve MPDSR implementation. Thank you.
Thank you very much, Mary. Indeed, action is really required in order to address the blame culture at all levels of the health systems. So thank you so much for your presentation, and you will receive some questions later. I see already some questions in the chat box. So thank you so much. Please put all your questions in the chat box. Now we will start with our panel discussion. Dr. Alison Moran, our unit head of maternal health, will facilitate the session. So over to you, Alison, and thank you very much.
Great, thanks so much, Francesca and Mary and everyone who's joined today. It's a great opportunity to be together today to discuss this important topic. So thanks to all the participants who are joining. And now, as Francesca said, we're going to have a really exciting panel discussion with colleagues to really talk about examples of how our colleagues have worked to overcome the blame culture using the different strategies of the framework that Mary just outlined. So first, let me introduce our three speakers. First, we're going to hear from Ms. Vida Amikukula, a registered midwife with a master's degree in public health from the University of Ghana. Vida has experience in community health issues, training for midwives, behavior change communication, and research related to maternal, newborn, and child health. Vida is currently pursuing her PhD at the Amsterdam University Medical Center, and her PhD work has a component of how to engage communities in reporting and participating in MPDSR. So welcome very much, Vida. And then we also have Ms. Gloria Bitwimba Siso, who's a registered nurse midwife by profession with a master's degree in public health from the University of Western Cape, South Africa. Gloria is currently working as a health specialist with UNICEF Namibia and is responsible for maternal, newborn, child health, including immunization. Gloria is leading the work on quality improvement and MPDSR, and she's also a PhD candidate with the University of Western Cape in South Africa. Welcome, Gloria. And then finally, we have Dr. Robert Mwemba, who's a National Professional Officer with WHO in Uganda. He's a technical officer working on maternal, newborn, child, and adolescent health. So thank you very much, Robert, for joining. So I'm going to ask each of you a question, and then you can respond to the question, and then we'll go to a second question. And if we have time at the end, we'll have a minute or two for you to give us some of your overall final thoughts about this. And so since we have limited time, I know it's going to be tricky, but I'm going to try to ask you to really limit your response to 3 to 4 minutes if you can. And then we'll have more time in the Q&A as well for people to follow up and ask you questions. So first, I'm going to start with Vida. So Vida, what are the core competencies needed for frontline health workers to prevent the blame in MPDSR, and what's being done in Ghana to strengthen this? And what type of results have you seen? Over to you, Vida.
Thank you very much, Alison. Hi, everyone. Yeah, just like Mary presented, for individuals to be aware and own up the MPDSR process, it is very, very important to be able for health workers to exhibit key competencies in their work. The first competency that I see as very necessary is evidence-based practice. Yeah, for frontline health workers to be able to integrate current evidence and see what works best for their clients, it is very necessary that we use available evidence that is out there already. And fortunately for us, we have a lot of guidelines that have been drafted out of evidence, things that have worked in other places. So in Ghana, we have the maternal and child health guidelines running through various levels. We have guidelines for managing pregnancy, childbirth, the immediate postnatal period. So it is very, very important that frontline health workers in maternal and newborn health are able to utilize these evidence-based guidelines and standard operating procedures to be able to offer help and care to their clients. When we go by these health guidelines, it helps to reduce suspicion. And so when issues come up, the team is able to have a discussion. And so it prevents this individual name calling and name shaming. Another thing is that usually when new midwives qualify, they are sent to facilities where you already have professionals who have been there for years. And sometimes, although these young ones have all this knowledge that they are coming from the institution with, it is very difficult for them to be able to use the knowledge that they have gained from school, because then we have somebody who is there and says, oh, I have all this professionalism. I remember when I came out from midwifery and I was posted to a facility, my first day of reporting is that you should do whatever you are told. And so the senior midwife there was like, I have to take some off time. So can you just take over? And looking around the patients or the mothers who were on admission, there was no way I could handle such cases. So I was bold enough to be able to come out and say that I'm sorry, although I'm just from midwifery, I have some, some areas that I'm not able to go. So can you just guide me and lead me into this? And it all worked out well for the client and for ourselves. Another area of key competence is leadership. Leadership and teamwork. You cannot take teamwork out of leadership. And usually every effective leader will work to ensure that individual health workers and the team as a general have the autonomy to be able to speak up, to be able to come up with issues as and when they occur. And also when in the assignment of duties, we have to look at individual expertise, the skills that individuals have to be able to assign duties and assignments when it comes to maternal and newborn health. Usually we do not look at all this expertise, but then as long as you are a midwife and you are assigned to the facility or to a department, then your name comes on the duty roster and you are expected to perform certain functions. And you have instances where these functions are outside the ability of the individual caregiver. And so it leads to issues. And when these challenges or errors are made, then there is this blame issue of who is responsible. Instead of asking what happened, people tend to ask who is responsible. And so individuals are pointed at. And that is where all these blame issues starts coming up. And so it puts midwives or frontline health workers in a very dicey position of speaking up or taking up issues when it comes to audit processes. Then they are silent because, like Mary said in her presentation, people tend not to speak up. And when you have instances where people are bold enough to come up, then sometimes it leads to gunfire. They come all out and there is always confusion and within the team. Another area of competency that is very, very important is learning and improvement. I think that frontline health workers in maternal and newborn health have a wide array of skills in both obstetrics, neonatology, public health, social science. It carries them along. And all these skills and knowledge is to help them to be able to maneuver their way through the complex healthcare system. So once individuals are able to learn and implement what they have learned through their education, through their training, then they become confident enough to be able to implement and take up decisions that work well for mothers and their families. However, we have instances where people are so stuck in their own corner. They don't want to move on. Even when new things come up, people feel comfortable doing the old things. So you have instances where even a nurse can take over from another nurse, and then you don't have any checklist to check what is supposed to be done. You don't follow any guidelines. So people can close and go to work, and you have people calling them at home. What was done for this mother? What is supposed to be done for this newborn baby? So there's a lot of confusion within the system. So the moment errors come up, then the who comes in. Who is responsible? Let's look for the person instead of what went wrong as a team, so that the team comes together to make sure that things work out well. We can go on to talk about communication. Communication is an effective tool in ensuring or doing away with blame. Whenever individuals within the team are able to communicate well, communicate what is supposed to be done, what has been done, where did the errors occur, then it makes it easier for the team to accept whatever error has happened and avoid blame. However, we tend to hide things from each other. So you don't have this straightforward line of communication from one person to the other. So when issues come up or errors are made, or there's an adverse event that happens with a mother or a newborn, then the who comes again, who is responsible. Then names are mentioned. And this is what usually brings down the morality of most health workers. So what is being done in Ghana? Up to 2003, not much was done in the area of MPDSR. Or after 2003, between 2009 and 2011, there were standardized audit system that was put in place to ensure that health facilities and teams are able to come together and audit the cases as they occur. The country rolled out the national training for regional and district hospitals to be able to carry out the audit processes. However, within the specific health facilities, we also have these maternal and newborn coordinators who were responsible for putting together data on maternal and newborn death and liaise them to the district and the regional levels for audit processes to go on smoothly. So all these things were going on until the maternal death audit guideline was well developed. So that one is formalized now in Ghana. So we have the maternal health guidelines, which is being used by health facilities to guide the audit system. However, the issue of perinatal death guideline is still in working and it's not formalized as at yet. The Ghana Health Service strategized to roll out MPDSR in the year 2018, when preparations were fully in line and things were about to roll down, then COVID struck. So everything was put on hold again. And then somewhere at the end of 2019 and early 2020, the Ghana Health Service tried hard to start to put together training for MPDSR at regional, district, and health facility levels. So all these things are in place to be able to help health workers to build their competencies in maternal and perinatal death surveillance. We are yet to start the national rollout of MPDSR. However, at institutional level, most institutions have their systems, they have committees running to ensure that audits are carried out in the right process and in the right way.
Great, thank you.
Yeah,
so
what
much.
has worked? If you look at the—
Sorry, Vita. Sorry, we're way, this is so fascinating, but can you try to wrap up in the next minute or so we can move on?
So yes, thank you very much. So in addition to the national level, we have the professional associations, such as the Ghana Registered Nurses and Midwives Association, and also the licensing agency, who try to put up competency-based trainings once in a while, mostly in leadership and teamwork, and also evidence-based training, to be able to help frontline health workers develop their competencies and ensure that once the MPDSR process is rolled out, we have very competent staff to be able to carry it along and own them. Thank you very much.
Thank you very much, Vita. Very exciting, the work that you're doing in Ghana, and really excited to hear more as things are rolled out. So thank you so much for sharing. And now we're going to move to Gloria. And the question we wanted you to try to respond to, Gloria, is what are the strategies that you've promoted in Namibia to get management or senior team members to engage in the process of reducing blame around MPDSR? Over to you, Gloria.
Thank you very much. In Namibia, we engaged few strategies, and these strategies, before I specifically talk about them, there were things that really drove us to engage those strategies. The first one is that we used the opportunity of my PhD research protocol, because then by that time I've gathered data. At global level, there were some discussions actually around 2015-16, to develop, they were developing the WHO quality of care standards, and also the issue that most of the preventable death can be quality of care. So I used that opportunity to use the research protocol is, evidence of what is happening around the world. We also looked at what were the emerging issues within the Ministry of Health, because for you to bring something new, you need to look at will the person listen to me. So at that time, the ministry were also, discussing about developing the general standards for the hospital. Then there were also some discussion with the WHO to support some quality management standards. So using those windows of opportunities, we were able to support the Ministry of Health update their national guidelines to ensure that the new evidence on preventing maternal and perinatal death are included. The guiding principles on no blame, no shame that are included. So it was really a good opportunity to initiate the discussion. We also, with the leadership of WHO, was able to support development of some key strategies like the Women and Child Health and Adolescent Strategy. We also supported the ministry with the Every Newborn Action Plan, which also has a very focused strategy on improving the quality of care. We also did some training to improve the capacity of the ministry. But this training has to involve those who are involved in caring for the mothers during pregnancy, delivery, and postnatal care. You cannot just train the implementers. So we needed to ensure that leadership, their supervisors, they were also on board, because they are the one who has to run this agenda. And this was a very key strategy for us. And at the end of the training, these facilities, they were provided with a monitoring tool, that they are using in order to capture data, in order to ensure that as death occurs, they are able to capture that information. And this spreadsheet has been used now in a few facilities in the country that were trained since 2019. And since 2020, just at the start of COVID, we have been discussing with the Ministry of Health to integrate this tool into the DHIS2. And the discussions are at an advanced stage as I speak. We are nurturing, the relationship, as Mary was saying. One of the strategies is to ensure that the team, their relationship is actually good. How did we do that? There's something that we innovated that was done in Namibia. Immediately after training, all participants were followed up with their sites. Why? Because sometimes when you come from a training, you go back, there are things that you cannot change at your level because you are just an implementer. So they were followed up and supported so that they are able to brief management and also to orientate management on the new knowledge and skills that they've learned, and also to help them set up, revitalize where the committees were not functioning, where the committees were functioning, encourage them on the new principles that have come, and also look at the previous, the way they used to conduct their reviews and support them to strengthen that. So what I'm trying to say is that the functionality of the teams in Namibia are such that confidentiality, no name, no blame, is the language of the committees, so that it's promoting individual awareness, so that everybody is aware of their role, their responsibility, and management is on top of the agenda. So I will discuss more as we continue discussing, but the management is, well, they were able to buy in because of how this MPDSR was introduced. It's not something that came on, but we worked on ensuring that we build on the existing structures, we build on the policies within the government, we build on the key emerging priorities for the Ministry of Health. Thank you.
That's great. Thank you very much, Gloria. Some important lessons learned there. Thank you so much for sharing. And now I'll move on to a question to Robert. So Robert, we're wondering if you could tell us a little bit about the policies that are in place in Uganda related to MPDSR, and how do the existing policies help support overcoming this blame culture? So over to you, Robert.
Thanks, Alison. Good afternoon, everyone. So in Uganda, we have the RMNCH investment plan, which highlights MPDSR as a key priority in improving quality of care. And as part of this investment plan, the MPDSR guidelines have integrated the no blame, no shame culture. And so we have operationalized the removal of identifiers in case notes during MPDSR sessions throughout the country. But one of the challenges is that this hasn't been implemented adequately, especially at lower levels, because obviously there's still a fear of possible repercussions, especially at community level. But at the national level, this is what has been ongoing. We have weekly MPDSR meetings. And during these meetings, we notify, we review, we report, and we draw up action responses without apportioning blame. And these sessions, as I said earlier, they are ongoing nationwide every week. And if you could please repeat the second question, Alison.
Sure. No, thanks a lot, Robert. So just talking about the policies that you have in place, and then how those policies have helped to improve the blame culture in Uganda? And
Yes,
I think you've addressed some of that already. Do you want to add some more? Please go ahead.
As I said earlier, one of the key strategies has really been in operationalizing the removal of case note identifiers. But otherwise, I think that's, and we've of course been training people on these MPDSR guidelines nationwide. And so the only difficulty really has been at the lower level, especially in involving the communities. But facility teams are fully aware of this, and they're capable of conducting MPDSR sessions with a no blame culture, no blame concepts. They are familiar with it. But involving the community has really been a challenge because they have been slow to basically adapt to this system. There are cultural issues there. So people are afraid of possible repercussions, especially physicians, midwives. And so that's where really the challenge lies. But so far, facility teams have managed to adapt this no blame concept really well.
Great. Thank you so much, Robert. That's really helpful to know about some of the learnings. Those are some really important lessons learned that you're sharing. And then we'll move on to the second question for each of you. Vida, we'll go back to you. This is actually a good transition because we were going to ask you a little bit about community engagement and how does community engagement for MPDSR look in your context, and how could it help strengthen the trust between communities and the health system? And then maybe you could just give us an example of how community engagement can help to reduce the blame culture. Over to you, Vida.
Yeah, thank you very much, Alison. Yes, just like Marima was talking about, community engagement is very, very necessary to be able to avoid the blame culture. When you look at the health system structure of Ghana, we have the lowest level as a community-based health planning and services system. So this system is supposed to be an integral part of the community. So if we really run well through this system, then we shouldn't have any issue at the community level at all. During the development of the maternal death guidelines, audit guidelines, the issue of the role of the community came up in the discussion. However, when the audit teams are being set up, no community representative. We don't have community representatives on the audit committees. And so when issues come up, such as medical legal issues, communities who want to take their health institutions up, when it happens that way, then health institutions within themselves will start blaming each other within the system. So it is very, very prudent for us to have a very well-structured engagement with the community to ensure that MPDSR system works very well. There have been instances where I've been involved in deliberations in the community to be able to prevent issues from escalating to another unwanted situations. So we had a situation where a newborn baby died and the mother came into labor, very healthy, baby was doing well, labor was progressing very well. Then the baby was born still, fresh stillbirth. And this was communicated to the mother first, and then the husband was brought in. But then the family immediately said, no, they are not accepting it because when the mother came in, nobody told them that there was anything unusual about the mother or the baby. And so their baby has been exchanged, and it was a huge issue because they had relatives who were also in the law and other things. So this went through into the community and they had to send delegates, of whom I was part. So we had to go into the community. Fortunately, on our team, we had a member who came from that community. So we had to go meet with the chiefs, the community leaders, to be able to give them the details of what happened during the birthing process. The unfortunate thing is that the results of the audit system is not even communicated back to the family members. Indeed, usually we use medical jargons, medical terms, and these family members don't understand. If you tell them that your wife's BP was high, blood pressure was just shooting, and the mother got fit and died, they understand fits in a different context. When it comes to cultural issues, they understand fits, and they will tell you that no, my wife or my family member never had fits. So it cannot be possible for them to have fits in labor or during the laboring process. So it is very, very important for us to communicate very well. Understand that we, apart from the medical or biological issues, we also have the social cultural context, which we need to incorporate into our care. When mothers or families come on admission, we need to be able to communicate and determine their preferences and sociocultural needs. Once we do that, and adverse events happen, it becomes easier for us to collaborate with the community to find solutions, so that even it helps the community to avoid future occurrences, similar occurrences in the future. So it's very, very key. Community engagement is very, very necessary for us to be able to reduce blame at all levels, not only from community to the health system, but also within the health system itself. Said that there have been areas where in some communities have organized themselves to go to the health facility to attack people, trying to attack health workers, destroy properties, just because communication was very poor. So community engagement is very, very key if we want to have a smooth process with the MPDSR. Thank you.
Yeah, thank you so much for sharing that really relevant example and experience with us. Very, very helpful, Vida. Thank you so much. And next, I'll move on to Gloria. So we're just talking a little bit about the review meetings for maternal and perinatal death reviews of deaths, and how we can work better to ensure that blame is prevented for individual staff and for managers during those review meetings. So have you had any success with interventions in your setting, and would you mind sharing them? Thanks, Gloria.
Thank you very much, Alison, for the question. I think we have a lot to share in Namibia. I hope there will be another platform for us to share in detail what is happening. Actually, our hospital review meetings are composed of at least 7 expert team members. It can be more than that, but not more than 15. And these team members were actually reduced after the skills building workshop, which was very good. They meet weekly. They are encouraged to meet on a weekly basis because we know in Namibia, maternal death, they are not so much, they don't happen often, but we have a lot of perinatal death. Therefore, for them to catch up with the number of perinatal death, they have to meet on a weekly basis. And then these meetings, they are formulated in such a way, in a systematic manner, so that they just don't come and don't know where to start. And this was also part of the capacity building. So they review systematically. The chairperson reminds the members, about keeping and maintaining confidentiality. Reminds them about the no name, no blame. I think all those who have been trained in MPDSR, if you ask them one principle, what I've noticed, what they will remember is actually the no name. Everyone is going to remember no name, no blame. Which is actually a good thing. And then once they do, they've done that, before they start with the actual review for that specific case, for that specific thing, they also have to follow up on previous recommendation. Last time when we met, we agreed that we recommended few actions that needed to be addressed for us to prevent similar cause of death. So they go through the follow-up on those recommendations, and then so that they are able to assess their performance every time they meet, whether it's weekly or every second week. And then they are using the monitoring spreadsheet that I talked about, which is few selected indicators. And then they will review the case using a prepared case note. So this case note that is prepared is without the name of the providers who are involved in the case. Is without the name of the client, the mother or the baby. The reason is so that the issue of blame is not attached, because previously we have learned that before the training that some people would not come to the meetings because they were involved in the care, and then they are being blamed that they did not do 1, 2, 3, and therefore they would not come. And now what they are doing is they have to, those case notes without names have to be prepared 24 to 48 hours and shared with the members, so that when they come to the committee, they have read through the case and they don't take time to go to the next case. and therefore they will go through the process of agreeing on the type of what caused the death, what was the underlying cause of death, and also come up with the modifiable factors. Is there anything in this particular case that we have done differently as a team, as a system, to save the life of this baby? There might be other things, but was there anything modifiable that could have been done differently? And this aspect for me is very important, because that's where you are able to come up with recommendations. You say that, okay, if this was something that we've changed, then it means we can recommend to make sure that we don't have a similar, a mother or a baby does not die again from the similar cause of death that happened due to a modifiable factor that we used to call avoidable factors. And then they use the modifiable factor to come up with recommendations that are smart, important. The smart part, I think all of us we are aware. But for me, the interesting part that I thought actually drives the team to make sure that the recommendations are implemented is the portal part of it. To make sure that the recommendation has the name of the person within the committee who is present that day, who is going to lead the recommendation. To make sure that, to ask themselves, do we have resources to implement this? For example, do we have guidelines that maybe we need just the fresher training? Who are we doing for this specific recommendation? Is it all the doctors? Is it all the nurses? Doctors, they are all over the hospital. So you have to be specific. What kind of cadre are you targeting? And who is going to lead this recommendation? You can say that Gloria is going to be the one, make sure that this action happens. But the interesting part, you have to make sure that someone follows up with Gloria in case I forget, so that when we come to the meeting, say, oh, I forgot, this did not happen. So I think that is really helping. For me, it's the best thing that is actually happening. And the important thing is, if you still continue to see after a number of reviews, you will still have similar babies or mothers dying of the maybe recommendation that we have done in the past and there's no change, then it means maybe we need to modify certain recommendation that we have made. Thank you so much.
Thank you so much, Gloria. Very, very helpful suggestions and recommendations. So let's just move on to the last question to Robert. So we wanted to talk a little bit about political priority and how Uganda has been able to use MPDSR and reducing the blame culture. Has that been successful at promoting maternal and child health as a political priority? Or how would you talk about that within the Uganda context? Over to you, Robert.
Thanks, Alison. And so in Uganda, there's the National Development Plan puts maternal mortality rate as one of the key indicators that need to improve. And as part of this, we have acknowledged that there's a need for multi-sectoral collaboration. And in this case, we have defined what each sector needs to do. And so MPDSR also falls into part of this overall strategy. So in terms of the blame culture, in a way, it has hindered the improvement of maternal and child health, because there's often a culture of blame shifting from on one end, the facility, on the other end, the community. So the community might blame the facilities, and facility staff might blame communities in case of delays, or sometimes they say that the patient, in case, used the traditional remedies like herbs, which resulted in a negative outcome. And so our approach has been to try to really dig into the real, to avoid this blame shifting, blame culture, and to try to address the real issues that are the reason behind mortality in this case. And so that's really what we've been doing so far. And this has been happening weekly in the national meetings, as I said earlier, and there are also district and facility meetings. And so we do this every week. We try to map out the deaths, what caused the deaths, and that's what's been going on in Uganda. And what avoidable factors we could work on to address these issues.
Wonderful. Thank you so much, Robert. So thank you so much. I think that concludes our panel. We're a little bit over time, but I just want to really thank our panelists for sharing such really helpful lessons learned and experiences. And so thanks again for your inputs and suggestions. And I'll turn it back over to Francesca for a few minutes for questions and answers.
Thank you very much, everyone. This has been a highly rich discussion. We're very thrilled for this. So now we will go to a Q&A for our panelists. And so just very briefly before closing the session. So this is a question for Mary. So how do we ensure that to maintain an adequate accountability system in place with a no blame and no shame strategy in MPDSR? So Mary, if you can answer this question, it's very an interesting question. Thank you.
Thanks, Francesca, and I'll do my best because I think I'm not sure what's meant by institutionalizing accountability. It's a big word, accountability. My colleague here at the University of the Western Cape just completed his PhD, Fidel Mukunda, and I see he's on. But he recently published a case study on maternal, newborn, and child health accountability mechanisms in one district in South Africa and found 19 accountability mechanisms in place, mostly targeting frontline health workers and managers. And that's a lot. But through his research, he also found that perinatal death review meetings were one of the most influential accountability processes because they're routinely done. They follow a no blame, no shame, no name approach, and they benefit the health system over time. And they see that change over time. And I've seen this kind of in the chat a bit as well, but I think it's really important that we think of MPDSR as taking a more holistic health systems approach and always be separated from individual disciplinary action in order to be successful. I don't know if that answers the question, but I do think that that MPDSR really can support a culture of accountability as well as enable change through the mechanism that it sets out to do, but it has to be done in a way that is of no blame. Thanks.
Thank you very much, Mary. Yeah, for sure, it's a complex, it's a very complex issue, the accountability, and needs to be addressed at all levels, as you just described. Thank you so much. So now there is a question for Gloria. Don't you think that involving mentors as technical support to the management of the maternal death reviews would reduce the blame culture? Thank you so much for the question. Gloria, would you like to answer to this?
Involving mentors.
Yes, involving mentors as a technical support to the management to reduce the blame culture during the reviews.
Okay, thank you very much for the question. I don't know what does that mean, involving mentors, because for me personally, I think if we engage another third party to actually oversee someone, that will also bring the issue of, of blaming. So I think for me, what should work is the way it is now, that the issue should be about not identifying who was involved in the care, and also not identifying who was the care provided to. Because within the committee, I can be a family member maybe to a case that we are doing. So once those names appear, or if I know it's Gloria was involved, that's where the blame part comes. But in terms of mentorship, I think it's debatable, but I think I'm not sure whether that's the right approach that I would suggest. Thank you.
Thank you very much, Gloria. So now we have a question for Vida. Since blame is somewhat related to cultural realities, don't you think that engaging influential actors as religious, traditional leaders, or other decision makers at community level via community dialogue or training could help overcome the problem? And Vida, this is for you. Over to you.
Thank you very much for your question. Yeah, so just as I said in my presentation, we cannot do away with community dialogue. we have to utilize all the opportunities to be able to engage community members. Within the Ghanaian system, Ghana Health Service System, we have the CHIPS, just as I said, the Community Health-Based Planning and Services System. And this system is well integrated into the community. So we have to be able to utilize that system to engage community members in dialogues. And usually these CHIPS health staff are able to organize community debates when issues do come up to try to explain to community members. But the experiences starts from the health facility. So usually before any community dialogue can go on, the start point is the health facility, because they do not have adequate information. So it is very, very important that as we are thinking of involving community, getting them engaged, then we need to strengthen our communication system at the health facility level, so that once we are able to give the right information to people, once it gets into the community, that same information runs through, and we are able to have a dialogue and discuss to be able to come to a conclusion on whatever has happened. So I do agree with you. And we have the community health committees also. And most of these community health committees have volunteers. And some of these volunteers are community leaders. Some of them are religious leaders. Some of them are women's group leaders who come together with the health team to form the community health committees. So it's an opportunity for us to utilize, to jump on and be able to involve the entire community into the MPDSR system. Thank you. I hope I answered your question.
Thank you so much, Vida. I think it's really pertinent that we really need to adapt to the local context and use every resource that we have in the context that we are operating in. There were so many other questions and comments in the chat box. Unfortunately, we will not be able to present it all and to answer to everything. If we can please put the slides on again, I will just give you a few closing remarks. Here it is. Okay, so please send me any questions to the email below that you find. If you have any queries on the work that we are doing on this specifically, or questions, you will receive all these materials by email for who registered for the webinar, where you can also access our research paper, and also the recording and slides will be sent to you, but we're also available on the Quality of Care Network website. So we are very glad that you could participate today to the webinar. There will be other additional in the future, other webinars on MPDSR, and we're really much looking forward to continue this work that we have on the blame culture in addressing the MPDSR to really improve the health of women and children and newborns. So thank you very much for attending, and looking forward to hear from you soon. Bye. Have a good day.
Bye-bye. Thank you.
Thank you, everyone.
Thank you.